Welcome.
Thank you. Good morning, Chairman Crownover, and I'm Ann Dunkelberg, Associate Director with the Center for Public Policy Priorities, and here appreciating the opportunity to testify in support of House Bill 3376 by Chairman Turner. The testimony that's being handed out to you, there's obviously a lot of ways I could spend my 3 minutes, and I'd say there's about 1.1 to 1.5 million good reasons to support this bill. I wanted to share with you some data that we pulled together on who the Texas workers are who would qualify for this Medicaid expansion. So on your testimony in front of you, you'll see on the front page a table that shows you the Bureau of Labor Statistics data for Texas, indicating what the median salaries are in those occupations, and basically we're showing you which groups of folks would qualify either as a single worker or if they were supporting one or more dependents. And one of the things that will jump out at you is that basically the industries probably that you would expect, anyone in the entry-level occupations for healthcare, food service, fast food, restaurants, hotels and motels, all of the construction trades, meatpacking and processing, and retail sales jump out at you as occupations where a very large share of the workers would qualify even at these very low income levels. One of the other things that I hope will come to your attention, because it's a big part of your responsibility in this committee, is that home health aides and personal attendants very much fall in this category, and since we have such a critical issue that we're facing with so many of the attendants who take care of more than 200,000 seniors and people with disabilities in Texas Medicaid are uninsured today, that this Medicaid expansion stands to potentially cover many, if not most, of that population. On the second page, there's a second table, which instead of looking at the level of the individual worker, shows you Texas industries, industrial sectors. This is census data for Texas. We've gone into it and we pulled out the U.S. citizen adult workers between 18 and 64 with incomes below 138% of poverty. You'll see there that we have about 1.5 million Texas adults working in those trades who are U.S. citizens and are below that income level, and more than half of them are uninsured today. You can see that some of the trades have much higher uninsured rates. In construction, over 70% of those workers at that income level are uninsured, and in the food industries and hotel industries, over 60% are uninsured today. I think it's just incredibly important to note that those sectors, along with construction, account for over half of the uninsured Texans who are working and are uninsured below 138% of poverty. So I think one of the reasons we wanted to share this is I think a lot of times there is this strong misperception that we're talking about an unemployed population, and in fact these are the hardworking front-level backbone of our working population, and they would benefit very much from this coverage. Thanks.
Coleman.
Thank you, Madam Chair. And I think it's why are they uninsured?
Well, I think
basically, what is the reason why?
The simple math, I think, is that the cost of coverage is so large relative to the wages that they're paying that it's simply not affordable within the current business models of those industries. We would have to pay a lot more for our hotels, for our restaurant food, for our houses, if all those workers were being paid for with what would basically be an extension of their wages.
And basically, the cost of buying that employer-sponsored coverage is prohibitive.
Oh, absolutely. At these income levels, it can be easily 40% of a worker's income if they were trying to cover their family.
Could we, as the state of Texas shows, could we do premium assistance to businesses or use another method of providing health coverage through private market for those recipients?
Well, I assume this is not a trick question.
No, it's not a trick question.
But it depends. Part of that answer is we need to draw down those federal funds.
Right.
So and we'll talk about this in our testimony on another bill. We certainly are not opposed to using the private marketplace to cover people in this income group, but we have got to have those federal dollars to be able to afford it.
When we were doing welfare reform back in 1995, it became very clear that the individuals as you mentioned, that work for the state of Texas through contracts with companies that care for our folks were basically making below or at minimum wage, and it's the same today. I mean, wouldn't it just makes sense to me that people who are working on our behalf for the Texans should be able to have health coverage.
Correct.
I'm glad you laid that out, because if somebody thinks about an individual working at minimum wage, they certainly can't afford the coverage that is offered by the company, if it's offered by the companies they work for.
And then relative to the comment you just made, in fact, our current income limit for parents on Medicaid, which was set in 1985 by this body without any inflation update since then, so it's literally approaching 30 years that we've used the exact same dollar amount for parents. If a parent works more than 10 hours a week at minimum wage, they make too much to keep their Medicaid.
Thank you.
Thank you. You know, there's another perception. I've been working for years on the health savings account for ERS members, and also have 4 adult sons that have gone in and out of employment, and then they have tons of friends, so I got really interested in that. And it's we have lots of experts in the room that spend lots of time trying to solve lots of problems. But what I have observed is often people that can well afford a high deductible health insurance don't want it. They don't see the need for it. I know I have tried to talk some very wealthy people into making sure. In fact, one was an investor, a radio talk show investor, and he had 3 adult sons with no health insurance because they didn't think they needed it. So I think we always paint a picture of people crying in bed at night because they don't have health insurance, and I really don't think that's true. I mean, everybody wants auto insurance when they have a car wreck. They would love to drive around uninsured if they could get away with it. So I think that's something that we don't talk about very much, and it's illogical, but it's out there.
It is, I agree, and I think you're right that a portion of the potentially eligible adults we're talking about here probably are not losing sleep at night over being uninsured, but others are, and particularly the ones with chronic health conditions, and those are some of the people who we think could be much more productive, less likely to end up in our ERs and jails if we could get them in a regular medical home.
Well, I think anyone needs to be in a medical home, but a lot of healthy young people just don't want an annual checkup. They don't need it for any reason.
And I believe that's the tension that states like Massachusetts tried to balance when they created their, you don't have an absolute mandate to get coverage, but you have a penalty that you pay that's actually much smaller than the cost of insurance, but it's still a penalty to try to get people's attention because the system has to be there to pick them up as a safety net when they do fall. So there are clearly folks who will choose to stay uninsured, even with a penalty in place.
And it's bigger than we would dare think, also.
I probably am not the best. I don't know that I have any numbers in my head about the proportion that do that, but I agree that it is definitely part of it. However, in this particular population, again, we're talking about folks below around $27,000 a year for a family of 3. This particular population, even those who would like to get it and are willing to make a contribution toward it, there's just not an affordable option for them right now.
I'm sure. Chairman Coker.
Looking at your modeling and just looking at the different modeling, take-up rates vary greatly. Some of the models that I think are espoused in some of the studies are almost 100% take-up rate. We look at LBB at 522,000 in 2015. We look at HHSC at 776,000 in 2015. What is the model you're using for the take-up rate in Medicaid expansion?
Well, the center's not done any specific modeling of our own, so we're just trying to report to people, here's what LBB is modeled, here's what HHSC is modeled, here's what some of the national groups that are doing all 50 states have modeled, and you're correct that there is a whole range, and I think that's why you see cautious professional demographers like Dr. Murdoch and Dr. Klein doing a low, medium, and a high, with the medium probably falling somewhere in that 75% take-up range. I think, if I recall correctly, LBB did 65% in their model, so that does, the difference between 65 and 75 is pretty, and I would just say, for my purposes, I tend to look to that second biennium because clearly in that first biennium you're still ramping up, so I think the second biennium of numbers, 16, 17, probably is a better benchmark of where you're going to end up. But still, a difference of 10 percentage points in a take-up assumption is a lot of money and a lot of people. So I think probably that I look to the fact that the demographers are so cautious as a caveat for us all that we should not expect these estimates to be perfect.
What, as you see the modeling, I spent a lot of time looking at the exchange group because that is going to be the biggest bump that we get in uninsured, which, takes no action of the legislature in 2014. What do you see happening with that group? If we do no Medicaid expansion between 100 and 400%, do you have any feel for what's going to happen there with that exchange group that moves into the exchange that gets the credit to buy private health insurance?
If I understand your question, you're wondering what the impact of having potentially Medicaid-eligible folks from 100 to 138% of poverty be in the exchange?
And the whole group. The exchange group represents a large percentage. If we drop from, say, you use 2011 census numbers at 24% uninsured, and I know some people have modeled it at 28% off of new census numbers. Those are self-reporting numbers. We're not always sure if somebody who's in a hospital district who has maybe the gold card in Harris County, we don't know if they're counting themselves as insured or uninsured. So there's some variance of we're not exactly sure, but we go from 24% potentially down to 16, maybe even 15% with the exchange group, which I'm focused on in that it's a big group.
Should have brought a pencil, clearly.
Yeah, but it's a big group, and have y'all, I know Blue Cross Blue Shield is doing Get Covered. I heard an ad on that recently. What are you seeing in some of y'all's work that you're doing with that exchange group?
One thing I would say first is that I believe you're using a Health and Human Services Commission number in estimating the share of the uninsured under the ACA that you think will be picked up by the exchange as opposed to Medicaid. And I would point out that Dr. Murdoch and Dr. Klein's model actually suggests that it's about 50-50, and some of the national experts like Kaiser have said that about 53% of the coverage gains in Texas come from the Medicaid side of the...
And I know I can't hire an economist.
No, so I'm just saying I want to point out to the listeners that I believe we're leaving half the money and half the people on the table if we don't do Medicaid expansion.
And some of that modeling, and I think that's, we're working off these numbers, and some of that's 100% take-up rate, which we know, like right now we have 314,430 under the age of 19 that qualify for Medicaid right now that are not in the Medicaid program. Those are our children with lesser means.
We need to do better.
And we can do better. And so I'm just really interested in the impact. Everybody has concentrated on the Medicaid expansion, which I respect. But I also, I laughingly have said I'm a Republican that sits here and says I'm talking about the Affordable Care Act a lot in the exchange because that is going to be a huge impact.
It is. And the federal government just announced last week the availability of grants for all kinds of organizations to become navigators in the exchange and help people enroll in whatever coverage is available. If we have a Medicaid or a Title 19 funded non-Medicaid alternative like Arkansas has proposed, then they would be able to steer people in all of those directions. And I think one of the things that we've lost by our reluctance to participate and engage in the ACA implementation process is that we don't have our state government playing an active role in coordinating that whole navigator process. We are going to need an enormous amount of outreach. It's great that Blue Cross Blue Shield is playing a role in trying to support a web-based way to do that, and I know that consumers and healthcare providers across the state are trying to work together to make sure we can get lots of good applications for those navigator grants. I think outreach and application assistance are going to be huge for people to try to understand those new options and how they apply and what they can qualify for.
Okay, thanks. Appreciate it.
Thank you, Representative Howard. Thank you, Chairwoman. Can you explain to me who the population is
a brief description. Based on what Chair Colcourse is talking about, certainly there's a huge population we could cover with the exchanges, and that's a very positive thing, and we want to go that direction. But if we stop there and don't do the other part, who are the people that we are not bringing into the system?
Well, basically, if we were to only exercise the coverage that's available to us through the exchange and not take any action on accessing the Title 19 funds that are available, then we would be leaving without any coverage option the vast majority of the population we're talking about today who are below the poverty line. And the numbers are, at least two-thirds of this group are below the poverty line as opposed to above it, between 100 and 133.
So in other words, even though we would be doing a good thing by having the exchange and expanding options to those that need insurance coverage, we would still be leaving the working poor,
the poorest of the
poor without coverage.
Correct.
At a time when we have the possibility of also bringing them into the system.
And that's our biggest concern, not in any way to diminish the importance of the exchange, the benefits to moderate income Texans of having that. It's going to be an excellent thing for other working families. But when I look at these data about these occupations, these are people who straddle both sides of the equation. So you're going to have some construction workers who can qualify for the exchange coverage and some who don't qualify for anything if we don't take that.
So it can be an either or, but it could also be a both and.
Both and means more funding for our healthcare system, more premium tax revenues, more local and state tax revenues, and more coverage. Thank you, Chairman.